Very happy to be here today and share with you our final results from our phase 1/2 study of anakinra in MPS 3. My disclosures are listed here. So why did we choose anakinra? You've heard about a variety of different approaches today, and I'm sure yesterday as well. And the reason we chose anakinra was based on some data out of Brian Bigger's lab that was presented a few years back at one of these conferences, where they showed that in animal models of MPS 3A, who had neuroinflammation and high levels of inflammatory markers, that if they genetically modified these animals to increase the amount of interleukin-1 receptor antagonists that was present, that this resulted in decreased neuroinflammation, improved memory, and decreased hyperactivity. And so hearing those results, and collaborators and I got very excited about this because we recognized that there was a medication already FDA approved in pediatrics called anakinra that was a recombinant interleukin-1 receptor antagonist, meaning that giving this medication could increase IL-1 receptor antagonists similar to how the animals were genetically modified to increase these levels. And since it was already approved by the FDA for other pediatric neuroinflammatory disorders, this makes it much easier than a completely new medication to bring to a clinical trial. And so the study design that we chose is here. And the design was in part based on the fact that this medication had never been tested in MPS 3, but also because it's given as a subcutaneous injection. And so that means it's given just under the skin, much like an insulin shot, once a day. And we knew that that could be somewhat difficult. And so part of the purpose of this study was really to look at tolerability of this approach. We started out with an 8-week observational period to get a baseline of the outcome measures we were looking at, and then started the treatment at day 1, with the primary analysis was at week 8. And so we continued to enroll participants until we had 20 participants in the study who were treated at week 8. After this, all 20 enrolled into an open label extension through week 36, and then the medication was discontinued and we followed for an additional 8 weeks to again get data off the medication and look for any rebound effects. So the patient characteristics at baseline are shown here. In total, we enrolled 24 participants who ranged in age from 6 to 26 years old. The majority were white and non-Hispanic. We had about half males and half females in the population, and 83% or 20 of the patients treated had MPS 3A, 3 with 3B, and 1 with 3C. This is a pretty detailed figure, but what it shows is just the flow of patients in the study. And you can see on the left side, we've got the first 8 weeks of enrollment, who was treated and followed up. And then the right side of the flow chart shows you the long-term follow-up through week 36. So as I mentioned, we enrolled 24 participants. 1 was excluded due to persistent neutropenia, which is a known side effect of anakinra. And the other continued on into the study. Between enrollment and the primary outcome at week 8, we had 3 people discontinue the intervention, 2 due to the intolerability of daily injections, which, as I mentioned, was one of the primary things in terms of the safety tolerability or phase 1 part we were looking at. And then 1 had a grade 3 AE of increased agitation, that it wasn't clear that it was related to anakinra, but regardless, with discussions with the parents and other physicians, we decided to stop the medication, and that participant did continue on for additional follow-up, just off treatment throughout the whole study. So at week 8, as I mentioned, 20 treated participants rolled over into the long-term extension, and 16 completed week 36 of treatment. So here again, we did have some participants need to drop out due to the intolerability of the daily injections. So our first thing that we really looked at was safety. Again, since this was the first time this medication was being used in Sanfilippo syndrome, we wanted to make sure that we weren't going to see any different safety concerns or a different safety profile than had been previously documented in other groups. So on this slide, I show the adverse events that occurred in at least 5% of study participants. On the left side are the SAEs, or serious adverse events, of which there were 2 during anakinra treatment, but neither of those were considered related to the anakinra treatment itself. We had a lot of injection site reactions, as you can see in the bottom part of the chart on the left, but those are anticipated and very similar to other populations treated with anakinra. On the right side, we've got the non-injection adverse events. And here, the first column, does the pointer here work? Let's try. Oh, that's working. So on the left side, we've got on treatment, so 23 participants, and then the right two columns are after treatment. So since we did not have a placebo, we were looking at the incidence and event rate during treatment versus the 8 weeks after they had gone on off treatment. And what we found here was really, I would say, overall as expected. So one of the potential side effects of anakinra is that because it's an anti-inflammatory medication, it decreases the immune system somewhat. And so we did expect to see a bit of an increase in things like upper respiratory infections, which we did find. You can see here 30% during treatment, 17% off treatment. And things like neutropenia and thrombocytopenia were also a little more prevalent in the treated group. And now to look at the outcomes or the efficacy of anakinra treatment. So what I'll first show here is the Sanfilippo Behavior Rating Scale. This is a scale developed by Elsa Shapiro and colleagues that we chose to use because of its specificity to Sanfilippo syndrome. And this SBRS is, if we're short, has 6 different outcomes, or domains and clusters is what they're called. And those are shown here in these different figures. So we've got mood, anger, and aggression, social emotional dysfunction, lack of fear, executive dysfunction, movements, and orality. And the figures here show the effects of the treatment with treatment of anakinra over time. And I'll just call your attention maybe to the top left figure here to orient you to what these figures are showing. So on the y-axis here, so up and down, is the domain or cluster of the SBRS. So up here we've got mood, anger, and aggression. And on the x-axis, we have the study visit week. And so the green box here, which hopefully projects, is the treatment period, so 0 to week 36. And then to -8 here is untreated. And then after 36 to 44 was also off treatment. And then I would just have you focus on the black squares here. The gray squares are just a sensitivity analysis that we did in addition to the primary analysis that matched our primary analysis. So looking at the black lines for this first top one of mood, anger, and aggression, what we saw in all of the outcomes here, except lack of fear, was a relatively stable scores, relatively stable scores from week -8 to day 0. And then with anakinra treatment, we see this gradual decrease in the SBRS scores. And a decrease in the SBRS is an indicator of improvement. And that decrease was statistically significant between week 0 to week 8 for mood, anger, and aggression, and continued to be statistically significant by week 36. And again, we see a similar trend in the other clusters and domains, except for lack of fear over here on the top right. And when we first saw that there seemed to be no effect on lack of fear, we kind of wondered, well, why is it that all the others have the exact same trend, but that one doesn't? And how we explain that is that there's been previous publications showing a correlation of lack of fear with atrophy of a part of the brain called the amygdala. And we did not expect that anakinra could restore a part of the brain that had been atrophied. And so it's possible that this is actually somewhat validating to the other findings that we did not see any impact on lack of fear on the SBRS. Okay, so one of the other outcomes we looked at that we developed for this study was called an individual clinical response. And this individual clinical response was designed based on a caregiver panel and publication that was done by Cara O'Neill and colleagues to really find out from the caregivers, what are the outcomes, what are the problems that they care most about? What should we be looking at in our clinical trials? What should we be focusing on? And so based on that publication, we chose these 15 items that are shown here on the left of the sleep disturbance, hyperactivity, et cetera. And at the very beginning, asked one caregiver, because we always want to have the same caregiver answering the questions each time, to choose 5 of these that was most important to them. And in this way, we were able to tailor one of these outcomes to specifically what was problematic to that family with their child. And so in doing that, they then scored each of those 5 items on a 5-point Likert scale that's shown down here in terms of how stressful that item was to them and their family. And there again, we saw a similar response as we saw in the SBRS. This figure is set up the same way as the previous ones, where we have a stability before treatment and then a decrease in the individual clinical response that is statistically significant compared to baseline. And again, here too, a decrease is an improvement in this outcome. And one thing I forgot to point out in the last slide, but that we did see here as well as in the SBRS, is that after treatment, we saw this rebound in symptoms very consistently, where the scores would rebound 8 weeks off treatment back up to baseline. And then another way to look at another outcome we included was the Autism Parenting Stress Index. And the reason we included this was because the items on it seem to be very similar to the items reported in the caregiver survey papers that we had used for individual clinical response. And I list the items here. So this survey was developed for parents of kids with autism, but a lot of similar concerns to parents of kids with Sanfilippo syndrome. And again, using this outcome measure, we see a similar response of somewhat stable, although there is a trend down in here with some variability in this measure between -8 to 0, so the observation period, but a statistically significant improvement in time with treatment over the 36 weeks. And again, this rebound back to baseline when the patients went off anakinra. And finally, we included what's called a multi-domain responder index. Now this we based on a study for MPS 7 enzyme replacement therapy for using this approach that takes into account the heterogeneity in the population that we're studying. So we all recognize that there's incredible amount of variability in disease severity, rate of disease progression, what's important at one point in the disease in MPS 3 versus later. And in any of the MPSs, there's a lot of variability. And so to have to pick one outcome and say, well, only if this outcome improves, then this medication is useful, that doesn't seem to fit right for us. And so we included this multi-domain responder index that looked at which of these 6 items listed here did patients improve on using a minimal clinically important difference over the course of treatment. And what we found is shown here. We've got 8 weeks, 16, and 36 weeks. The black area means the number of patients that improved with treatment. Gray is no change, and white is worsened. And so you can see here, we've got movement disorder, fatigue, parental stress, pain, behavior, and sleep as the 6 items included on this multi-domain responder index. And we found a significant number of participants did improve on at least one or more of these different items. And finally, to give a biochemical validation to these clinical effects that we were seeing, we did immunophenotyping, which means taking the blood from the patient and putting it through a machine that tells you the number of white blood cells, monocytes, CD4, CD8 cells, these immune cells that are part of the body's response to an infection, response to inflammatory trigger. And we looked at the changes in this inflammatory profile, I'll call it, over time and correlated that with how many outcomes a participant improved on. And so I'll call your attention to the right side here. This on the left is just from the last slide of the MDRI. But what I show on the right is that on the bottom, we've got the number of MDRI outcomes And if you look at the black line, this would be the number of MDRI outcomes that have improved over 16 weeks. And on the y-axis, we have the absolute change in that immune marker. And generally what we found here was that the greater the increase in CD4 cells, the decrease in CD8 cells, and the decrease in monocytes. So this would be interpreted as moving towards a less inflammatory environment, the greater number of outcomes that a participant improved on using this MDRI approach. So it just gave us another way to validate the clinical findings we were seeing. So in summary, for this phase 1/2 study of anakinra and MPS 3, there were no new safety concerns. There were no anakinra-related severe adverse events. For dosing, which in the interest of time, I didn't get too much into, but this study also was looking at what the most effective dose was. And we found that 75% of participants required a dose increase from 100 milligrams to 200 milligrams. And that was based on 2 caregiver-chosen most bothersome symptoms. And so this 200 milligram dose is the dose that we'll be carrying forward into a phase 3 study. In terms of efficacy, improvement in mood, anger, and aggression, social emotional dysfunction, movement and orality from the SBRS, and caregiver quality of life from the APSI and ISR was seen. There was variable improvements in pain, sleep, fatigue, and disordered movement. And the change to a less pro-inflammatory environment did correlate with more benefits on the MDRI. So I'd just like to finish by acknowledging the collaborators on this study. We had funding from the Cure Sanfilippo Foundation, and study drug was provided by Sobi. And of course, a very special thanks to the families that participated in this study. It was a difficult one to participate in. There was a lot expected from them, and so we're just so appreciative of everything they did to make it a success. And my contact information is here. If we have time, I'm happy to take questions. If not, just come find me afterwards.
Thank you, Linda. We do have 10 minutes that we can use for taking questions. This is incredibly exciting data, and it addresses a very important clinical challenge that families and individuals with Sanfilippo face. And I really applaud the efforts of the investigators and the funders for tackling this very difficult problem.
Hi, yeah, just wondering, obviously, that the trial is complete, and we know not a lot of families are getting this drug off-label. What are the next steps for Anakinra, and what do you see the future?
Yeah, great question. Thank you, Glenn. And I just really want to acknowledge again the funding from Cure Sanfilippo Foundation, the support of Glenn and Kara on this study. They worked with us in development of this and outcomes and recruitment and just really made a difference. So thank you for that. In terms of next steps, we have applied for funding. We've designed a phase 3 placebo-controlled trial, which we have been in discussions with the FDA about. We just met with them last week about a few concerns that I think we're moving through. And so it's really just a matter of funding. That's at the NIH to be reviewed in February, and hopefully, fingers crossed, we will get funding and can move forward with it. It is the type of study, though, I will say that the funding requires a 6 to 12 months planning stage, which I think it will need because it will be a multi-site study. And so in terms of thinking ahead of when the phase 3 study would enroll, it would be at the earliest, probably summer 2026.
I'd also like to highlight there's not just funding and support that comes from Cure Sanfilippo, but one of the co-founders, Kara O'Neill, was one of the drivers of important scholarship that helps define outcome measures that are associated with this study. So very important original scholarship around the evaluation of Sanfilippo. So that's very unusual to see from advocacy-based organizations. So kudos to Cure Sanfilippo and Kara for that, and her colleagues. Other questions? Excellent, one moment. Kim Angel from the International MPS Network. It's all yours.
Hi, Linda. Thank you for that presentation. Amazing results. Will the study only be focused in the United States, or will there be trial sites or study sites elsewhere globally?
It's a good question. So right now, the application we've put in is for 2 sites in the United States. And so, but moving forward, we're happy to open it up and look at expanding to international sites. I'm just recently doing this with our Humira clinical trial, where we, with collaboration with John Mitchell, we're opening 3 sites in Canada. There are some difficulties and challenges in making it happen, but I'm definitely happy to talk with anybody who's interested in making that happen for the Anakrina program.
Additional questions? We have time, and you opened up the topic of a Humira expansion trial. So I'm going to go there.
Okay.
So you and your colleagues have worked, in addition to the work you presented on Anakrina, you've worked on another biologic that interrupts inflammatory processes called Humira, which is obviously a well-known drug to treat rheumatoid arthritis. And I believe that trial was MPS patients with bony disease, including MPS 1, 2, 6. Excellent. So can you talk about what you are thinking of for that? Are you at liberty to, please?
Yes. Yeah, I actually had a few slides in the talk yesterday on it, but then I cut them out in the interest of time. So this is good that we have a few minutes here. So we started the Humira program over 10 years ago. I was still at University of Minnesota, and it was in follow-up to seeing the incredible work by Lila Simonera, who Joe mentioned today, her work on PPS. She had also done animal work showing that the joints in an animal model of MPS 6 look like that of rheumatoid arthritis, and that there was elevations in a molecule called TNF alpha, which is a known target for treatment of rheumatoid arthritis. And in her animal studies, when she targeted them with an anti-TNF alpha therapy like Humira, it's an IV version called Remicade, the animals improved their mobility, they decreased the inflammation, the joints looked much better. And so in talking with her at that time, they were moving forward with PPS, and in talking with her, we decided we would try Humira since it was available already to be used. And we started the study. We did a pilot that is published of 2 patients where we did see improvements in joint range of motion in most of the joints that we measured. We saw a decrease in chronic pain. And so then we opened another study about 8 years ago, and that was funded through multiple foundations. So the MPS Society, the Ryan Foundation, and we had enrolled 5 participants, and there too found in the first 4, that was a placebo controlled, that there were improvements in joint range of motion, decrease in pain, and all the participants that were in the study did continue on it in clinical care afterwards. So why didn't we finish it? And why are we opening it in Canada? Well, the reason is because in the United States, it's not difficult to get Humira approved for joint contracture in MPS compared to Anakrina. And so we really struggled with enrollment because most families did not want to travel, understandably. If you can get it prescribed by your local physician, it's got a well-described safety profile. There was some published data on it. But in Canada, the patients were not able to get it covered. And so John Mitchell saw that opportunity, and the Canadian government put out a call for applications to expand studies from other countries to open them in Canada. And so this is where I see sometimes these opportunities come up, and we're happy to do. That was a great opportunity for John. He applied for that funding and now has funding to open 3 sites in Canada. And so I'm hoping within a year, we'll finish enrollment and finally have an answer on how effective it is for joint disease and chronic pain in MPS 1, 2, and 6.
Thank you, Linda. That's very gratifying news to hear. And it highlights an interesting challenge when we think about repurposing drugs. If drugs are approved, families get access to them. Recruiting the trial to get a full approval is a challenge, but you've sort of taken lemons and made lemonade out of them with your Canadian partners, which is excellent to hear.